Hello everyone, I hope you are doing well. So, the topic for today's discussion is pulmonary embolism. Pulmonary embolism refers to the thrombosis that originates in the venous system and then it embolizes to the pulmonary arterial circulation where it blocks the blood supply to the lungs. Pulmonary embolism and deep venous thrombosis is a continuum of one clinical entity, that is venous thromboembolism. So the source of emboli can either from lower extremity, which is more common, and from upper extremity, which is a rare source of emboli. So lower extremity is the most common source of emboli causing pulmonary embolism, mostly arise from deep venous thrombosis above knee, that is iliofemoral, deep veins of the pelvis and deep veins of the calf. Extremities can be seen in IV drug abusers. So what happens is thrombus gets detached from the primary source and it embolizes to the pulmonary vasculature via the right ventricle and pulmonary artery. The blood flow distal to the embolus is obstructed, which leads to increased pulmonary vascular resistance and pulmonary arterial pressure. Also increase right ventricular pressure, and if the thrombus is large, it can cause acute cor pulmonale, which is a right-sided heart failure. Dead space is created in the areas of the lung that are ventilated but not perfused. This leads to hypoxemia and hypercarpia, which leads to respiratory drive tachypnea. So all the risk factors of pulmonary embolism can be covered in Virchow's triad, which includes stasis, injury to endothelium and hypercoagulability. So for stasis like prolonged bed rest, inactivity, congestive heart failure, stroke within 3 months, air travel of more than 6 hours, these will all lead to stasis. Injury to endothelium will occur from trauma, surgery, priativity, inflammation. And the hypercoagulability states can include pregnancy, protein C arrest deficiency, antiphospholipid syndrome, OCPs, hormonal replacement therapy, heparin-induced thrombocytopenia, selective estrogen receptor modulators taken in breast cancer, and malignancy. So the patient will have sudden onset of shortness of breath and clear lungs on examination. There will be pleuritic chest pain, cough, hemoptysis, syncope when there is large pulmonary embolism. Signs can include tachypnea, tachycardia, rales, S4 heart sound, decreased breath sound, dullness or percussion, and low-grade fever. So the chest X-ray is most commonly normal, and it is however essential to rule out other causes. Most common abnormality which can be seen on chest X-ray is atelectasis. Westermarck sign can also be seen, which is a focus of oligemia, vasoconstriction seen distal to pulmonary embolism, but it is uncommon. Hampton signs is a wedge-shaped pleural-based consolidation associated with pulmonary infarction. It is also uncommon. I have pictures attached. So these are some signs that can be seen on chest X-ray of pulmonary embolism, but these are, as I have told you earlier, these are uncommon signs. See Hampton signs, pulmonary wedge shape due to infarction, and the Westermarck sign. Another important investigation that needs to be done is arterial blood gases. It will show respiratory alkalosis, which means that there will be low partial pressure of oxygen, low partial pressure of carbon dioxide with high pH. Increased AA gradient. Normal AA gradient makes pulmonary embolism less likely. So in ECG, the most common finding will be sinus tachycardia, and most common abnormality can be non-specific ST to T wave changes. So in acute small pulmonary embolism, there will be only sinus tachycardia. However, in an acute massive pulmonary embolism, there can be anterior T wave inversion, as shown in the picture. In lead 3, you can see T wave inversion, and there will be right bundle branch block. And it's a very important pattern of pulmonary embolism. You will see S wave in lead 1, Q wave and T wave in lead 3, which is a right ventricular restraint. So you can see in lead 1 there is S wave, and in lead 3 there is T wave and Q wave. Lower extremity Doppler is also important, but if the test is negative, then it's of little value. and if it is positive, then no further testing is needed because the management of DVT and pulmonary embolism is the same, therefore no need of CTPA. And negative results occur in 50% of patients with proven pulmonary embolism, so negative result will not rule out pulmonary embolism. CT angiography is most commonly sought first line diagnostic test, and it is the test of choice in most medical centers. It can visualize very small clots as small as 2 millimeters. It cannot be performed in patients with significant renal insufficiency because it requires IV contrast. So pulmonary angiography has now superseded by CT angiography because it involves contrast injection directly into the pulmonary artery branch after percutaneous catheterization of femoral vein. It is the gold standard investigation. It is invasive with significant mortality rate of 0.5%. So this is a beautiful picture of pulmonary artery, and it is showing an embolus which is marked by a line. D-dimer level has high negative predictive value. It is performed when clinical suspicion for pulmonary embolism is low. High D-dimer level is of little clinical significance because they can be seen in myocardial infarction, congestive heart failure, or pneumonia. Low D-dimer level, less than 500 nanogram per ml, helps rule out the disease, and therefore it has high negative predictive value that if the test result is negative, then it rules out the disease. And particularly where clinical risk is low, it is a good choice to perform these tests, and it has high sensitivity and low specificity. So the mainstay of treatment is heparin and oxygen, and therefore acute anticoagulation should be done, and the options include low molecular weight heparin, fondaparinux, and thrombolytics. So for heparin you have to check APTT for its effectiveness, and it should be commenced immediately on the basis of clinical suspicion. Do not wait for the studies to confirm pulmonary embolism if clinical suspicion is high. It reduces further propagation of clot and the risk of further emboli. The agents which are used are enoxaparin or dalteparin. Enoxaparin 1 mg per kg sub-Q twice daily, and it comes in the dosages of 20 mg, 40 mg, 60 mg, and 80 mg. So you have to decide according to patient's weight. Dalteparin is also used, and it is given 200 international unit per kg sub-Q once daily. It should be given concurrently with warfarin for at least 5 days, which is also known as bridging therapy. It should not be discontinued until INR of more than or equal to 2 have been achieved for at least 24 hours. Fondaparinux is an alternative agent to more low molecular weight heparin. It is given in 5 to 10 microgram subcutaneously once daily. It can be considered in patients who develop heparin-induced thrombocytopenia. Thrombolytics is used in hemodynamically unstable patient with acute massive pulmonary embolism. It speeds up lysis of clots. The agents used are streptokinase and tissue plasminogen activator, which is recombinant form, so RTPA. It carries risk of intracerebral hemorrhage with no mortality benefit, so it should be given with caution. Long-term anticoagulation options include warfarin and rivaroxaban. Warfarin should be started with heparin on day 1, and therapeutic INR which should be achieved is 2 to 3, and it requires regular INR monitoring. So whenever you are giving heparin, you have to monitor INR on the daily basis, and you have to start it with the heparin because warfarin takes up to 5 days to be effective, so you have to give it from day 1 with heparin. Rivaroxaban comes in the formulation with 15 or 20 milligrams. It is an oral anticoagulant agent and does not require regular INR monitoring, which is a benefit. Advantages of rivaroxaban over warfarin are: in acute therapy, it's as effective as low molecular weight heparin plus warfarin combined, and it is in long-term therapy, it is as effective as long-term warfarin therapy. So, and you don't need INR monitoring for it. Duration. So how do we decide for what duration we have to prescribe anticoagulation? So we have to see the clinical perspective. So for example, it's the first distal DVT, and if it's a first venous thromboembolism event which is secondary to a reversible and time limited risk factor, then you will give anticoagulation for 3 months. But if it's first unprovoked VT event, unprovoked means that you are not able to identify the cause, or it's idiopathic VTE. So, or if the patient is male, because they have higher risk of recurrent VTE than females, and if there are elevated D-dimer levels 1 month after stopping the anticoagulation, then you will give the anticoagulants for more than 3 months. If it's a second venous thromboembolism event and those patients with persistent prothrombotic risk, then you have to give anticoagulation indefinite, that is for lifetime. Cancer associated VTE involves low molecular weight heparin for 6 months, then switch to warfarin for life or until cancer is cured. Inferior vena cava filter can also be used in patients who have contraindication to anticoagulation, or who have suffered massive hemorrhage on anticoagulation, or when there is recurrent thromboembolism despite anticoagulation. So this is the picture of inferior vena cava filter, and it is placed in the anterior vena cava, and it will capture any blood clot. So that's it for today. I hope you learned something from this video. If you do, please like my video and subscribe to my YouTube channel. Share my video with your friends so you can spread my channel. And thank you so much for watching.